So yeah, sorry for the technical glitch. Yeah. So once you have placed the bridge, you have to ask the patient to maintain the oral hygiene, and on every follow-up, check if the bridge is partially debonded. If it is there, you can remove and again place it back. So Barak in 1993 concluded that the success of the Maryland Bridge is somewhere around 80%, and the failures were attributed to reasons like caries, and there's a learning curve if it is not done very properly, unplanned design of the wings and the occlusion, and unaesthetic appearance of the Maryland Bridge. So Priest in 1998 reported that the high relative rate uh, and classified Maryland Bridge as long-term restoration or the permanent restoration. So in conclusion, the basic advantage of using a Maryland bridge is the conservation of the tooth structure. You do not have to go conventionally and prepare the full coverage restoration for the maxillary, central, and the canine. And pre-planned design and meticulous attention to the procedural details will contribute to the success of the Maryland bridge. And long-term restoration for replacement of maxillary anterior teeth, you can use Maryland bridge. So in future, reinforced fiber polymer framework with porcelain veneers can be used. And main advantage is it is conservative. It allows mobility, high bond strength, and there's no graying with use of the lithium disilicate myline bridges. And because of it, there's no grain. So coming down to the next topic, uh, which is gingival tissue retraction. So what does gingival tissue retraction means? It's basically the displacement of the gingiva away from the tooth. What are we looking at? We are looking at the tooth margins that we have to record in our impression. So whenever we make an impression, we want our gingiva to be displaced away from the tooth. So it is basically deflection of marginal gingiva away from the tooth or displacement or dilatation. So why is gingival retraction necessary? Is to obtain the bulk of the impression material for maximum accuracy, to improve the tear strength of the material, to avoid voids in the marginal areas, and to obtain the accurate dies for the fabrication. So critical circular width is 0.2 mm, which is around the prepared tooth. So objectives of the gingival retraction include to widen the gingival sulcus to provide access for the impression materials to go inside, to obtain a perfect die with accurate margins, to cut the die and to get the accurate margins, indirect prevention of plaque accumulation, marginal caries, and marginal gingivitis. Also to enhance and access and prevent damage to soft tissue during the cavity preparation. Now, criteria for gingival retraction, medicaments include it should be effective. It should provide adequate hemostasis and control the gingival circular fluid or GCF, clavicular fluid. Also, there should be no irreversible tissue damage and there should be no potential systemic effects of the medicaments that are used for gingival retraction. Now, how to retract gingiva? There are basically three methods, that is mechanical, chemico-mechanical, surgical, and the combination of any of the above. So in mechanical methods, we have rubber dam, we have copper band, we have aluminum shells, we have retraction cords. Also, we have made a mechanical pack that is made of a zinc oxide eugenol. In surgical methods, you use a gingitage or electrosurgery or laser. So gingitage is basically using the electrocautery to nick off the marginal gingiva. And in lasers also, what we do is we remove the marginal gingiva to make sure that the prepared margin is exposed to the naked eye. So chemico-mechanical methods include mechanical retraction with chemical impregnated cord. So while we use the cords, you can use a single cord technique or double cord technique, the infusion type, and the every other tooth technique. So retraction cord are basically the twisted cords or the braided cords or the knitted cords. You can see the images on the screen. Chemicals that are used for retraction is epinephrine 1:1000 ratio. Biologic fluid coagulants like the aluminium potassium sulfate, aluminum chloride, which is 5% aluminum chloride, and surface layer tissue coagulants include 8% zinc chloride and silver nitrate. So in single cord technique, this is what most dentists commonly use. It is for 1 to 3 prepared tooth with healthy gingival tissues. A largest diameter cord that fits inside the sulcus should be used. In double cord technique, we use two of the cords. The smaller diameter cord is placed first with no medicaments inside, because the more you put inside, the medicament has chances of going into the PDL space. So no medicament with the first smaller cord, and larger diameter cord can be placed after there with medicament. The double cord technique, during impression making, the second cord is removed first while the first cord is still in its place, right? So once you put your putty light body or say any other material, the most of the times what you'll see is the retraction cord comes out with the impression material. So it is especially useful when the multiple preparations are done and when the gingiva is too thick. So yeah. So you specifically design Dento infuser with ferric sulfate, which is 20% that is used as a medicament. It is effective in achieving the homeostasis. Infuser is used in burnishing motion in the sulcus. So you have to like put it around the tooth circumference, three in 360 degrees around the sulcus. So in every other tooth technique, it is generally done for the anterior teeth. It avoids strangulation in the gingival papilla. A single cord or double cord can be used, and cord is placed in the most distal part of the prepared tooth, and adjacent mesial tooth is left unretracted. So procedure of doing retraction is keep the necessary armamentarium ready. Your tooth needs to be isolated. If the field is dry, it will be easy for you to work for gingival retraction. Dry the field with your air. Cut the sufficient length of the cord to encircle the tooth. Dip the cord in the astringent, squeeze out the excess, and then start placing. Twist the non-braided cord to facilitate the placement. So if the cord is non-braided, you twist the non-braided cord and then you place it there. So if it will unwind inside the sulcus, it will give you more retraction. So loop the cord around the tooth prior to pushing it into the sulcus, and then start retraction in the interproximal area. Because once you start in the interproximal area, your retraction will not come out easily. If you start somewhere in between, you place your cord, and once you start pressing ahead, the retraction cord may come out. So angle the instrument towards the teeth and push directly into the area, and angle the instrument slightly towards already packed gingival cord. So if you try packing towards the cord which has already been packed, your cord will automatically go inside slowly and steadily. If you try pushing it away, your retraction cord may come out. So cut the excess if you find any, and wait for 8 to 10 minutes and wet the cord before removal. You have to wet the cord, remove if you are using a double cord, remove it, and clean the dilated sulcus thoroughly and dry the tooth surfaces, and then make your impression. So instrument angle towards the root and not parallel to the long axis of the tooth. This is a very important point. So you have to finish the placement of the distal end of the cord unless it overlaps. So once it overlaps, you have a room for picking it up with the tweezer and then remove and then place your impression material. So there are new materials that are available in the market. Expasil is a very good material. I personally use it. So Expasil is a temporary gingival retraction system. So it is like a tip, as you can see in the figure down. So it comes with a tip, and you can push the material inside the sulcus, and you let it stay there, and it reflects the gingiva. There's something called as a GingiCap, gingival retraction material. So it is basically a foam sheet with that material placed inside, and you ask the patient, you put the material along the sulcus of the tooth, and you ask the patient to bite on that GingiCap. So because of the pressure of the foam, the material pushes inside the sulcus and it causes a gingival retraction. So Gingitrack gingival retraction material for single, you can use it as a foam, or for multiple teeth, you can place it in the tray and then do the retraction. So gingival retraction cord with wet drip-free astringent. So astringent gel like aluminum potassium sulfate, you can dip it in the solution, squeeze it out, and then place the cord. So another thing is HNH impression technique, which the HNH stands for the hydrophilic and the hydraulic pressure. So a low viscosity polyvinyl siloxane material can be placed over the tooth. So you can put your light body and then put your putty impression over it. So and then once you make the impression, all of your sulcus is recorded in the light body. There are reinforced gingival retraction cords like nylon polymers and twisted. The nylon polymers are twisted with the cotton fibers in the ratio of 1:3. So it is not very soft and it is not very hard to place the cord inside. And there are radio opaque cords with silver impregnation. Also, you can use your Teflon tape as your gingival detection because it does not absorb water. It is very easy and it is resistant to tearing. Your non-braided or braided may get stuck with your cord packers, but Teflon, because it is way soft and you can twist it and turn it, you can place it inside the sulcus. So with this, our basic aim to do the gingival detection is because we want to look for our margins, and that should be easily recorded. So gingival displacement is an important procedure for fabricating the indirect restorations. Several techniques has proven to be relatively safe and efficacious. But the thing is, what suits a clinician is the personal choice. So the choice of technique depends on the clinician's preference and the clinical situation and the operator's preference, right? With this, I conclude my presentation, and thank you so much, everybody, for patient listening. And I thank Team Cynodent for giving me this opportunity. Thank you.